Hi everyone and welcome back to the Longevity Podcast. I'm Jess.
And I'm Lee.
And for anyone who's new here, we are both clinical pharmacists working in primary care, which is a GP practice in the UK. So in this week's podcast, we are going to be discussing lower back pain. So the reason why we've chosen this is because it's actually thought that up to 60% of the adult population will experience some kind of lower back pain within their lifetime. And also, I myself have suffered with low back pain, so we thought that it might be a good podcast to do in terms of going through the physiology and the treatment of lower back pain, but also given my experience of lower back pain and how I've dealt with it and what I've used to help with it, to give patients a bit more of a personal point of view of someone who is experiencing it.
Yeah, so I mean, you've said you've experienced it. When you go into a GP practice, the first thing you look out for with low back pain is to rule out any red flags. So do you want to go through the red flags?
Yeah. So when, like Lee said, when someone comes in with low back pain, there's 3 different types of back pain that we will check for. So the first one is nasty back pain. So it's called the 3 Ns. First one is nasty back pain, which is any red flag symptoms that could be, there could be some underlying pathology that's, not too good that will need referral. Then there's nerve pain and then non-specific. So like you say, the nasty back pain, so the red flag. So
it's tuna fish, isn't it?
Yeah. Okay. Do you want to do it then? So
the T is trauma.
Yeah.
U is unexplained weight loss.
Yeah.
N is neurological deficit, so that's bowel or bladder.
Yeah.
Then the A is age, so I believe it's under 20 or over 55.
Yeah.
Then the F is fever.
Yeah.
I is IVDU.
Yeah, so like inflammatory causes.
Yeah, then we have pain. S, which is
steroid use.
Yeah. And then we've got H, which is a history of cancer.
Yeah.
Mainly breast, prostate, kidney, and thyroid.
Yeah. So with these red flags, basically what we're trying to rule out or rule in potentially would be things like an infective cause. So sometimes you can get like real bad infections within your spinal column, which can cause back pain. If that happens, then it needs referral to secondary care for some antibiotics or something like that. We're also looking out for malignancy. So that means you've got maybe a potential tumour within the spinal column, which is causing the back pain. We're also trying to rule out that there's no cord compression. So a big one is something called cauda equina syndrome, which means that there is cord compression. If you do have that, it can then lead to things like paralysis, and obviously we do not want that. And so all of these could be potential causes of these red flag symptoms, and so would definitely need referral to a hospital setting.
Yeah, and when you talk about malignancy as well, a lot of the times it can be primary, so it means like it happens at the site of the spinal cord, but a lot of the time it's a sign that your cancer spread from the prostate, breast, etc. So once you've ruled out these red flags, then you can maybe go to the nerve cause of back pain, can't you?
Yeah.
Which is more the sciatic.
Yeah.
And that's normally where your leg pain's more severe than the back pain.
Yeah.
It's normally unilateral, meaning it affects one side more than the other.
Mm-hmm.
And there's a few tests that you can do just to sort of confirm it.
Yeah, so this is the type of actual back pain that I do suffer with, and anybody who has suffered with it in the past will know that it is like a tingling pain down one side of your leg. So my particular sciatic pain started at my lower back and it goes through my buttocks, down the back of my hamstring, and then it'll go into the back of my foot and my ankle. And it's not a dull pain, it's just a very irritating type of pain. So I think, like Lee said, if you do experience a pain like that, it is likely that it is sciatica. Now, the causes of sciatica can be quite a few different things. One of them, I think what you were kind of alluding to, is something to do with the discs. So within your spine, you've got your vertebrae, which is the bony structures within your spine, and in between them, you've got a spongy-like substance, which is your disc. And sometimes, if you've had trauma to it or something else, it can cause it to protrude and press on the nerves in the spinal cord, which can then lead to these symptoms. So one of the tests I think is called the slump test, which I will discuss in a little bit, but I've had this test done on me because I've recently been to see a chiropractor. So it's basically where you put your head to your chest and then lift you lift both of your legs, and if you're unable to lift one of your legs to a certain point, it can indicate that there is some disc involvement. So if you suffer with these type of symptoms, it probably you could do it potentially at home. And if on the good side you're able to lift it a lot higher than the other side, then it might indicate that there is disc involvement, like I say.
Yeah. And then going on to the next type of back pain, it's non-specific, which is normally about 90% of the presentation that we do get within the surgery. And that's just that we can't identify a true cause. But when you actually look back, a lot of patients will have non-specific back pain, and it's normally due to poor lifting, obesity, occupational hazards. And it's like you said, in terms of the disc bulge, for example, that's due to poor lifting.
Yeah.
Normally, like you're getting up or picking something up off the floor, you haven't got a neutral spine, so then the bulge occurs because there's too much of a gap and the disc can protrude out. But in terms of how we manage back pain depends on which category it is for the first thing, and then we'll just go down the non-specific route.
Yeah.
And a lot of patients don't like to hear it, but movement is the first point of any back pain, really.
Yeah. So I think we also discussed this prior to the podcast where we said, and this has been, I can relate to this, where pain doesn't always equal damage. So I think when patients do have back pain and you're saying, okay, you need to get up and move, it does hurt. And I can vouch for that if you do suffer with back pain and you're being asked to move, especially when you get up first thing of the morning, the pain can be quite intense. And you do feel like, wow, if I'm in this much pain, surely there's some kind of damage going on inside my body, which isn't normally the case. And so it is important to put that in your mind, that even though you are experiencing this pain, it is actually going to help it in the long run.
It is. And if you just give analgesics, which is what a lot of patients like, you're just masking the problem, and it's always going to be there. But then you've got the added risk, which we'll go on to, in terms of abuse, addiction, and it leads on to that. But one of the things that we looked at was, so we said that movement and physio was the first protocol, but what does a patient want from a consultation? And that can sort of depict the outcome, can't it?
Yeah.
So there was a survey done in Manchester, actually, and it was across 12 practices, and they asked GPs what they thought was a valuable contribution to the consultation, and they asked patients what they would like to get from it. So we went through this yesterday, and you got them all right anyway. So in terms of an examination, 90% of patients thought that this was essential or useful, where that was compared to 70% of GPs. So, you know, it's quite close, but then this is where the differences come about. So 60% of patients thought that an X-ray was essential or useful, whereas only 3% of GPs agreed with that. Referral to specialists, 57% for patients, less than 1% for GPs. And then allowing nature to take its course or enabling movement, only 43% for patients against 83% for GPs. So straight away, if you've gone into a consultation and you're not meeting what the patient expects, or you haven't described what the potential outcome is, their treatment's already off to a bad start.
Yeah.
Isn't it? And then I just wanted to go into the X-ray part of things, because that's what everyone thinks. Like, you know, I must have some damage there. Send me for an image.
Yeah.
Do you want to go on to them?
I mean, yeah, so we don't usually send patients for imaging unless it is, like we discussed before, a red flag. You know, if you've got any red flag symptoms, then that would warrant some kind of imaging potentially. But even if you've got some nerve pain and then obviously the non-specific pain, we wouldn't recommend doing it. So I think we mentioned before that one of the risk factors, or one of the reasons why you would get back pain, can be due to age. So as you do get older, you will get some natural changes within your spine, and it's just, they're called degenerative changes, aren't they? So it just means that it's kind of wear and tear as you're getting older. Obviously, you can get some, you know, changes within your spine. And so if we do send patients for imaging, say an MRI for instance, or, you know, something like that, it can pick these changes up, and it actually might not be the cause of the patient's back pain, but if they do get a diagnosis of degenerative changes, a patient can then kind of cling onto that diagnosis and then actually experience more pain, or they contribute that diagnosis to the pain when actually it might not have been that was causing it in the first place. So you actually can get worse outcomes if you do send a patient for imaging.
Yeah, because that happens in other areas of medicine. So for example, if you've got a patient who's got chronic anemia, there's no point in sending them for a full blood count every 3 months, because you know it's going to come back low. But then from a legal point of view and an ethical standpoint, really, you have to act on that.
Yeah.
So it's time wasted. Like you just said, then you are expected to have wear and tear.
Yeah.
It can make them focus on that. And this is where it comes up to, there was a study where it said only 1% of imaging,
Yeah.
well, is essential really, because only 1% of patients have a specific cause.
Yeah.
Yet, despite this, I think there was over 19 million consultations reviewed in this meta-analysis. 25% of patients are still sent for imaging.
Yeah.
So that's probably from a legal point of view, you don't want to, I don't get sued or anything like that. And then there's the peer pressure from patients as well. But going from that to treatment.
Yeah, so first line treatment, like we said before, is always to do kind of physical movement. So it can be anything like walking. Yoga is quite a good one if you practice yoga. Some patients obviously will.
And it is
do
hard.
that.
I mean, I've
Yeah.
started to do it. It's
So
very
that's
hard.
that's if kind of like if that's something that you would like to do. Being referred to the physio, that's what a lot of patients will get, and they will give specific exercises. A lot of them are sitting down exercises, which anyone can do. But yeah, just being more mobile is the first thing that we would suggest.
Yeah, and there's a greater access to physios now due to the way that the NHS has been structured, which is good. I mean, we see more and more consultations with the physios. The only problem I say with the whole process is that the patients still don't want to give that time. So you see like the first 1 or 2 consultations and they're still asking for pain relief at that point.
Yeah.
And they're not willing to give it the time that it deserves because, like we said, it's probably the best healer is movement in this situation.
Yeah.
And we only found out certain reasons why when you went to the chiropractor. So they were talking about the CSF, which is the cerebrospinal fluid. That's basically surrounds your central nervous system.
Yeah.
It provides a cushion, provides nutrients, removes waste material.
Yeah.
And in certain back pain, you can get neuroinflammation.
Yeah.
And the idea is that if you stimulate this fluid, which can be done by walking, yoga, cycling, it then removes the toxins and can provide pain relief.
Yeah.
So that's the basis of that sort of.
Yes, that was quite interesting, wasn't it? You can I'll speak about this in a little bit, but when I did go to the chiropractor, they do certain movements, and it is all to try and help that CSF fluid flow more freely. Which we like we said we didn't know about that until we seen the chiropractor, and it was quite interesting.
Yeah. But yeah, so my advice would be to give more time to the physio and give them a bit more respect.
Yeah.
This idea that you don't need a pill to cure everything. Then going on to pain relief. So for years, paracetamol for osteoarthritis or back pain was number one. And we always say, take paracetamol, it helps alleviate everything else. But paracetamol alone wasn't more effective than placebo.
No. And I think it's just important to say on that point that paracetamol is a good pain relief for other types of pain. And I always advocate if a patient's got chronic pain, that paracetamol is one of the best types of pain relief that you can take for it if you take it regularly. But for these types of acute pain, low back pain, in studies, it was shown that it wasn't actually more effective than placebo when taken alone.
Yeah. So after physio, we're not going to paracetamol yet.
Yeah.
Going to anti-inflammatories.
Yeah, so things like ibuprofen is classed as an NSAID, which is a non-steroidal anti-inflammatory, which you can buy over the counter in this country. Things also like naproxen, that's another example of an NSAID. However, that's a prescription-only medication now, isn't it? But yeah, so that would be kind of the first line that we would say if pain relief is needed. After you've tried all the physio exercise and that hasn't worked, then we can give a short course of an NSAID. However, that can only be given to some patient cohorts, so they come with quite a few side effects. So just to name a few, is it can cause kidney dysfunction. So if you already have any underlying issues with the kidneys, you shouldn't be taking ibuprofen. If you have things like respiratory diseases, so one of them being asthma, it can worsen asthma. So you can take it in certain circumstances, but definitely seek advice from a health professional before you do take it. It can also cause stomach issues, in particular stomach bleeds. So when you are taking it, sometimes we will recommend that patients take a stomach protection alongside it, something like a PPI, so a omeprazole or lansoprazole. So again, if you have any history of any ulcers or anything like that, or have suffered with stomach issues in the past, definitely seek advice from a health professional. It can also cause things to do with cardiac issues. So if you've got high blood pressure, you've had a heart attack in the past, you've had a stroke, again, you shouldn't really be taking these medications, so seek advice from a health professional. Is there any others that you
No,
want
they're
to
the
touch
main
on?
ones. I mean, you're obviously meant to take them with food to try and mitigate the stomach issues,
Yeah,
but in patients over the age of 45, short courses we advise.
yeah,
Long term, a lot of patients do take them long term for other conditions such as rheumatoid
yeah.
arthritis, etc. But they have to weigh up the balance and risks with that because you see it on paper in university, etc. But now more and more I'm seeing more kidney issues due to, so they can cause acute kidney injuries, like you just said. I've seen numerous stomach bleeds with them despite being on protective therapy.
Yeah.
But the reason why do we give them? So they are so effective in terms of how they work because they prevent prostaglandins, which are the inflammatory, basically chemicals within the body. They stop them from being produced.
Mhm.
Of the idea of the side effects come from the fact that it's not really specific. It will still affect other parts of the body,
Mhm.
but they are effective in how they work.
Yeah.
But like with anything, it should be short course, it should
Yeah.
be monitored.
Mhm.
So if you are on these for a long time, you should get your blood pressure checked, you should
Yeah.
get your kidneys done.
Yeah.
But ideally, you shouldn't be on them for more than 2 to 4 weeks
No.
without any sort of plan in place.
Yeah.
So you can buy them over the counter, like you just said,
Mhm.
but
Just be careful with taking prolonged courses of them.
yeah.
Especially if you have any underlying health conditions, and especially the ones that we've mentioned.
But this is where the topical gels come in now, because a lot of patients go, oh, it's not as
Mm.
effective. They have been proven to be effective
Mhm.
with it being topical, so going onto the skin. Unless you've got really deep abrasions, it's not going to get absorbed to the quantities within the body as taking an oral tablet. And studies have shown that they actually don't have that much of a risk. I don't think the risk at all was increased over placebo for the gastric side effects or anything like that.
Mhm.
So if my advice would be to go for them first,
Yeah.
if you can localize and treat it locally. If it's like a systemic, like inflammatory somewhere, then take the
Yeah.
tablet. But what happens if either this is not effective or we can't take it? What do we go to next?
So then the next point of call would be something like a weak opioid. So that is mainly codeine that we would use. And I think cocodamol, which is codeine plus paracetamol, is something that I see get prescribed a lot. Again, so these medications are good for acute pain, which means that it's pain that is short-lived and it doesn't carry on. They're not recommended for chronic pain, so long-term pain, unless it is a cancer type pain, which is, I think, the best indication for opioids, isn't it? So which one of the only things that we should be using opioids for is cancer pain.
Yeah, after surgery as well, there are treatment protocols,
short.
isn't it? But yeah, it's
Yeah,
all
short.
monitored, managed.
Yeah.
And in some patients, you'll get, oh, codeine doesn't work for me. And that's due to the fact of codeine is not an active drug in its own right. It's got to be converted to morphine within the body. To do so, you've got to have the right enzymes within your liver. I'm not going to sip 2D6, I think, the top of my head. If you don't have enough of them, you don't get the effect. If you have too much of them, then you get side effects. You can get hyperalgesia from it.
I think you call like either fast metabolizers, aren't you? Which I think I am, because whenever I have taken codeine in the past, I get all the symptoms of like nausea, headaches, feeling sick, nausea, yeah. And it's not pleasant, so I just kind of avoid them. But
yeah. But one thing about codeine that gets me as well, so the maximum dose is 240 milligrams a day, and the equivalent to morphine is a tenth, isn't it? So 204, so it's 24 milligrams of morphine.
Yeah.
Now you will see prescribers do it left, right, and centre. You'll see patients advocate for it, and let's say the codeine is not effective. They want something more potent. So normally the next step is a morphine-based product, whether that be morphine capsules, whether that go into oxycodone, fentanyl, whatever that may be. They still keep the codeine there, and they don't understand that. You don't need that. It's only adding to the mix, like side effect wise, because the morphine, it needs to be converted to morphine to work.
Yeah.
So that's the only thing I can't get my head around.
Yeah.
You just take that away and then incorporate that within the morphine dosage.
Yeah, that's what you're supposed to do.
That's what you're meant to do. And it rarely happens.
That's usually for like chronic pain. We don't, I mean,
So chronic pain is where it's been around for more than 3 months.
Yeah.
Normally, and then acute is anything less than 3 months.
Yeah.
And this sort of brings us on to the problems that are happening mainly in the US, but it is happening more and more here.
Yeah.
Is the chronic opioid.
Well, opioid epidemic, isn't it?
Basically.
But So in GP practices across the UK, if pharmacists are listening to this, you will know that it's been there's been a big push for opioid and gabapentinoid. So we'll talk about them in a minute, but a push for medication reviews with patients who are taking them long term, and it is because these drugs are a drug of abuse. So obviously, like we say, codeine is converted to morphine, so therefore, everybody knows that morphine's really addictive. People may not associate codeine with being as addictive, but with it being converted to morphine, it automatically does mean that it does become addictive. So yeah, like Lee said, obviously you see patients who will be prescribed these medications and they're only intended to be used for short-term use. Unfortunately, sometimes they will get carried on without a review, and then it'll be a year down the line and the patient's kind of, cannot come off them because they're dependent on these drugs. And then in rare circumstances, but it does happen, the patients can then maybe start to buy drugs illicitly, in the street, and maybe go to harder things, maybe some morphine capsules, and then sometimes it's led to patients, taking heroin and things like that. So these medications, although they have their place within medicine, it's so important for patients to just recognise that if taken inappropriately, they can be dangerous.
Yeah, and morphine, from the top of my head, doesn't have a maximum dose.
Yeah.
There's obviously recommended limits and guidelines there, but it doesn't have a maximum dose because it's all based on tolerability.
Yeah.
I think there was a study of a woman who was 80 odd years old who had a dose of 200 odd milligrams a day and it didn't affect her.
Yeah. I think also on that though as well, you can overdose on them. So like, although there is no maximum dose, it just depends on how much your body can tolerate it. So again, with these medications, especially if you've got an older person and because all these medications are basically eliminated from your body by your kidney, and so it depends on how well your kidney's working. So if, for instance, you've got an older patient who is dehydrated, it's the middle of summer, the kidneys will not be working as well sometimes. So if their body can't eliminate that drug as fast as what it usually would, the drug can then accumulate, and then you can actually overdose on these medications.
Yeah.
So that's another important point to make, and that's why if you are taking these medications regularly, we would usually do kidney function every year. And if you are acutely unwell with an infection, or you've been dehydrated, you haven't been eating or drinking as well, you've had a bout of diarrhea or sickness, then maybe think about getting some bloods done, or just monitor yourself for any side effects of these drugs. So things like nausea, vomiting, constipation, headaches, confusion, and then also breathlessness. Like if you feel like your breathing's off a bit, that can be signs of overdose, or like you're taking too much.
Well, yeah, that's what I was going to say. A lot of patients aren't aware of the risks of them, and the medications are fine to take if they are in accordance with the regime. They're there for a reason, but the biggest thing that leads to death is respiratory depression, because opioids. So we use morphine in patients who've got COPD, for example, who can't struggling to breathe. So then we depress the breathing so that they can get more of a quality breath. And then in these patients who don't need it for that indication and it's just for pain relief and they've gone so far with it, they can just have their respiratory rate depressed so much that they don't breathe enough to live. Then you've got sedation, which is such an overlooked consequence, really. Everyone's, oh, you'll get sedated, you might get a bit drowsy, but the effects that can have is profound, whether you're operating machinery, for example, working daily tasks. A lot of falls happen. That's why a lot of people have, driving, there's drug driving laws that have been brought in due to it. And then normally what happens in this patient cohort is that they feel as though they've got to a point because you develop tolerance and then later on becomes dependency. You then have to add in different modes of analgesia. So you said before gabapentin.
Yeah.
So once you add them in, again, increasing sedation, drowsiness, there's going to be a point when you can't function and your neurological effects are just going to be so depressed that it's only going to end in one way.
Yeah.
So we've done a thing in Cheshire where we had to look around patients who are on gabapentin and make sure they're not on any concomitant opioids.
Yeah.
Because I think last year there was 600 people admitted in Cheshire who actually died due to the interaction between the two of them. And when you bring that up to patients, like, oh, I wasn't aware of that.
Yeah.
And then that sort of leaves a grey area then for professionals, because like you said, that there'll be patients at the surgery prescribed, what is it now, 120 milligrams of morphine or more, we've got to do a review. Yeah. So for them patients, you can't just stop a cold turkey. No. It has to be on a reducing regime. But then if that prescriber issues that, even though they've been on it for a long time and it's more harm to stop it abruptly, if anything does happen, they're still implicated in that. So it's sort of, where does the liability lie?
Yeah, and I think to be honest, this is why prevention is always better than like the cure. So obviously, a lot of patients will have been put on these medications years ago. Nowadays, we are getting better at not prescribing. So to try and do alternative things. So like we say with this topic in particular, my take-home message for any patient listening to this would be, please just try the exercises first, because that is going to be, although the studies have not been shown that that is the best thing for it, at least try that, and it can help it before trying any medications. Because as I think as health professionals, patients sometimes just think, oh well, they're not giving me any medication, and they don't really see the reasons as to why. So obviously we've just listed a whole host of reasons. Please bear that in mind when we are speaking to you, that it's purely for your safety that we're not giving you these medications. It's not because we don't want to or we want to see you in pain. It's because we don't want you to ever be caught up in the consequences of taking these long term. And obviously it would be for a health professional as a last resort to give these medications. So just bear that in mind.
Yeah, and at the same time, like I've said before, if a health professional gives out that medication despite the assessment and anything does go wrong, I have seen a lot of instances where patients will go after that health professional wrongly, in my opinion. And this is all created due to the culture that, we should have an agreement between the professional and patient, which I agree with. You should come to an agreement, but at the end of the day, it is the professional who's got the degree and all the knowledge behind that. And if they convey it and they don't agree with it, that's fine. But because you're in this position of a job, it's like, oh, you've got to give me this. You can't go to any other business or sector of the world and do the same thing. If you get what I mean, you can't demand something because they're in that role.
Yeah, it does make it hard.
It does, and there'll be people there, especially when you're newly qualified. That's when you've looked at it in a textbook, it never pans out in practice as it should do. But yeah, so there is a lot on pain relief. You could talk about it all day, but the take-home messages are, like you said, to utilize exercise first. We can't overhype the idea of exercise is going to be more beneficial, but they have found that if you do actively sort of discuss it with the patient and you don't say just get on with it, that's having a more profound effect than just letting them exercise on their own accord. If you are to go to pain relief, try and use localized topical forms such as the gels. If not, and you can take the anti-inflammatory, I would consult with anyone anyway, just to see what you're taking, see what your baseline is, and then you can go to weak opioids if needed.
For a short course.
All this is for a short course, though.
Yeah.
Because normally a lot of it, a non-specific back pain is a self-limiting condition in the majority of cases. If it doesn't, then you need to look at what's causing it. Is it something that's more sinister? Is it something that's more neurological?
And then just to touch on the sciatic type pain, so the same rules apply for that. However, obviously sometimes because it is a type of nerve pain, gabapentinoids, like I mentioned before, so things like gabapentin or pregabalin, which initially were anti-epileptic drugs, but they work on the central nervous system, so they can help with nerve pain, are not recommended. And then also things like benzodiazepine, so that's things like diazepam. You do tend to see diazepam used a lot for back pain, so they help with back spasms, but again, they're not recommended. And the reasons for that is because all of them medications, again, like opioids, you become dependent on them. They have risks of a lot of side effects. And actually, when you look back at what is causing the sciatica, it usually is just to do with inflammation. And so if you are given a neuropathic agent, it's kind of just masking the underlying issue and not actually treating the cause.
It is, yeah. I mean, we were thinking, why should we include this in the podcast? Because it's about longevity, living a healthier lifestyle. And we were looking at the fact that I think the UK and America are more largely affected than, especially Asia. Because when you look at, I look at Japan a lot because they've got a big culture, haven't they, where they sit down a lot on the floor, they get up, they have low. It's all about movement. We're such a sedentary country and population. And then there was something I read before that back pain is responsible for 60 million disability-adjusted life years worldwide. Meaning that a disability-adjusted life year, I think the best way to describe it is a year where you can't live to your full health. 60 million them
It's
are
mad.
attributed to back pain.
Yeah.
Something.
Yeah. So obviously, if you want to, if you are more active, like we tend to now have a lot of office jobs, don't we? Like where we work, a lot of people work from home. We sit at a desk. Like that is probably the biggest cause of my back pain, if I'm being honest. Like, and I will go into this in a minute, but um, you know, it just shows that
Well,
you know.
since you come back, obviously we've been lucky to go away a couple of times recently.
Mhm.
We've done a lot of walking on them holidays, averaging what 15 to
Yeah.
20,000 steps a day, non-sedentary, only
Mhm.
for a couple of meals, and then that's it. We're back up and out. We had no issues when you think you would because you're
Yeah.
using it more, and then we've come back. We're doing the clinics 7.5, 8 hours a day. You try and get up as much as possible, but then because you're sedentary or sitting in a weird position, your back is a lot more inflamed. It is painful
Yeah.
and does take a lot more time to adjust. But that's all due to inactivity.
Yeah. I know. And then just before we move on to the other things was that can contribute to back pain are excess weight. So that's another thing that you can potentially do to relieve your back pain is to lose a bit of weight. So if you do carry more weight, there's more stress that you're putting on your back. Then also improper lifting. So we did touch on this before. Again, I will touch on it again about my own experience because I think that's also been the actual initiating factor of why I developed back pain. But that can be anything to do with improper lifting in the gym, but also improper lifting in your job or just day to day. So we're supposed to lift from our legs, not your back. So if you are lifting heavy, you're supposed to kind of squat down, aren't you?
Yeah,
Make
squat
sure your
down.
back's straight as it possibly can be, and then lift the object that you're trying to lift. So again, just like incorporating that into your day-to-day life and being better at that will help with back pain. Also, if patients have got diagnosis of depression or anxiety, that can also increase your risk of developing back pain. And it's thought that it potentially might be to do with more muscle tension if you're suffering with stress or anxiety. So trying to do things like meditation or something like that, or just things to combat your anxiety or your stress can help with back pain, which might sound novel, but that's true. And then also smoking. So the thought behind this is that smoking can cause a cough. So they were thinking that it potentially could affect the discs because you're coughing a lot. And then also with smoking, it reduces the blood flow to your spine.
Okay.
So I found out yesterday, which I thought was quite interesting. So again, it's all to do with living a healthier lifestyle as well. Back pain, so where you might not have thought it's got anything to do with your lifestyle, it actually does.
It is. It's such a big presenting complaint in this country. When I
Yeah.
used to work on the A&E, I think I was only on there for 2 months.
Was yeah. Three, would have been 3 months, would it?
Yeah, 3 months. But a lot of the people that turned up were either paracetamol overdose or back pain.
Yeah.
And that was in that A&E
Yeah,
department.
it
That
is.
was literally the majority of them.
Yeah.
I'd say 70% were
Mhm.
back pain. And then when you looked at the demographic, I don't think any of them was due to a fitness injury. It was all due to overweight,
Yeah.
like improper lifestyle. And I'm not saying that's going to solve anything, but it's going to be a big
Yeah.
help. And like you said, you can affect yourself in a gym, but you just have to learn about technique.
Mhm. Definitely.
But yeah, so the plan for this one really is to try and look at it from another perspective in a future podcast
Yeah.
and look at it from a chiropractor's perspective
Yeah.
mainly.
Yeah.
See how it is without any pharmacological treatment at all. See what maneuverability techniques that they employ and how effective that is. I mean, you've done 4 or 5 sessions now.
5 sessions now. So it's probably best for me to like kind of speak about my experience with back pain then. So I've suffered with it now on and off for about 5 years, and I think that initially my back pain came from improper lifting in the gym. So like Lee said, it was actually to do with an injury that I'd been causing. It was because when I was younger, I used to do a lot of HIIT workouts with weights, and I think I just chose a heavy weight one day and was basically doing too many reps and not good form. And I remember me back kind of going, that was all I remember. And I was like, oh, that was sore. And then ever since then, I've always had issues on and off. So with these conditions, if anyone is listening who suffers from it, you'll know that they come and go. So you don't constantly have back pain like it is. It will go and then it'll come back, and it can be anything that will trigger it again. So I don't even know what's triggered it in the past, but this time when I've had the flare up, it was sleeping actually. So that also has got a lot to do with back pain, which we will explain in a minute. But I tend to sleep a lot on my front, which is the worst possible way that you can actually sleep if you do suffer with back pain. And I also fidget a lot. And this time I was sleeping on me front, and then I turned abruptly, and then just felt like my back had gone, and then I felt the sciatic pain. Obviously, I don't know what's gone on in the physiology of that, but something happened, and I was like, oh, okay, it's come back, and it is like the pain is quite bad, and this time it's been particularly bad. I think on a scale of like 1 to 10, I'd say it was about an 8. And it's obviously worse in the mornings. Now it does get better if I do move, but especially in the first few days, I found it really difficult because the pain was so bad. It was so hard to do what was going to help me. So I did use some paracetamol and ibuprofen. The paracetamol, like, it didn't touch it for me, and like you said, that kind of backs
That's
up the
been backed
yeah,
up in
it backs
evidence,
up the
hasn't it?
evidence because it didn't work for me. I did have some ibuprofen. You can buy esomeprazole over the counter now, so you can buy it from Home and Bargain. So I bought 7 of them and then took that with the ibuprofen because my stomach's quite sensitive to NSAIDs. So anyway, took that with it, and I did find some benefit from that. So then I was able to kind of move around more. Now, the reason why we ended up going to a chiropractor was because we were going away, weren't we, to Bali, and it was an 18-hour flight, and I just thought I physically can't be on a flight for that length of time.
Yeah.
I was quite scared, to be honest, but yeah, we went to the chiropractor, and so far it's been good. So they incorporate different techniques where they'll do some physical manipulation of your back. So they're trying to, I think, straighten your spine out because it could potentially be that could be a cause. They also do some deep tissue massage, and then I think in future ones they'll do things like cupping, which I think the idea behind that is to try and like get blood flow to an area, like we say, to then remove any toxins or any like inflammatory like responses, and then like help.
That's why massages and foam rollers are good, because
Yeah.
you're getting blood flow to the area without actually utilising the muscle. So that's a big thing.
Yeah, and then also I have been doing yoga, so I've been practicing yoga almost every day actually for the past month. Nothing too strenuous, literally 20 minutes every day, and I feel like that's massively helped me.
You've improved a lot. Your core
Yeah.
strength's really good.
Well, I think again, core strength is another thing that will help with back pain, isn't it? Because if you've got good core strength, you're able to utilize the muscles in lifting better because you're not using your back too much.
Yeah, and well, ironically, like, weight training is good, but balance and core strength
Yeah.
is the main thing for longevity, isn't it? That's what they're
Yeah.
sort of proposing
Yeah.
at this time.
Yeah, but with regards to the sleep thing that I said I'd mention, yeah, apparently you're supposed to, the best way to sleep is on your back, or on your side. I'll get us to we'll link some like pictures, or a link to somewhere where it tells you how you sleep for back pain, because I found that it has been helpful. You can also sleep with a pillow just above your knees, and that's supposed to give it a little bit of relief on your back. And then in terms of mattresses, we think that we do need a new mattress because ours is supposed to be a medium mattress, but I think it's a bit softer, isn't it, than a medium?
And we've only just bought it, by the way.
Yeah, I know, which is annoying.
Sorry
but apparently you're supposed to sleep on a firm mattress. Now, the reason for that is because if you think back to when our ancestors were around, they'd sleep on a rock, and so that was like that's how we've like evolved to sleep.
Yeah, but we do have to balance that up with how many hours of sleep you're going to get against the quality of sleep, etc. But yeah, in theory, that's what we're meant to sleep on, and we're meant to have a neutral spine throughout and that's why even if you change position, so if you sleep on your left-hand side, that's better for reflux as opposed to your right, because then your stomach acid can go up if you're on your right because of the angle.
Yeah.
There's loads of ways. Your sleep can affect, and it's horrible because once you're asleep, obviously you're unconscious and you don't know how you're being manipulated in your sleep. Sometimes you wake up and you're on your wrist, and that's done in for a week.
Yeah. But I think the main thing for me is that I wanted to get across is that it is a very painful thing, and it is hard to live with. And obviously with my condition, it does come and go, and it's only like this time I say I probably had pain for about 3 weeks, like where it was bad, and it really does, it really affects your mood. Like I was feeling really sorry for myself, and I couldn't exercise to what I was doing, and so it's just to like kind of reiterate that it is an actual thing. Like it is difficult to deal with, and especially if it's going on for longer than 3 weeks, and it can really affect your day-to-day life, and it can become really encompassing. But just try your best to do what like the health professionals have told you to do, and to seek maybe alternative therapy, so massage therapy, or like go and see a chiropractor if you can, because for me that has really helped me. And I think that, you know, ongoing, I fell in love with yoga now. It's definitely something that I'm going to be incorporating into my routine even when I do go back to weight training, because like you say, it's really helping my core strength. And I feel like I actually did my first weighted workout yesterday. It was only with very light weights, but I found that since doing yoga, my actual mobility and my the way that I'm doing my weight training has even improved.
Yeah.
So, you know, it's been good.
But yeah, so as a general, back pain isn't a novel thing. It is there for a lot of people, and sadly, in a lot of the cases, it's got an unknown cause. We've got to make sure you keep an eye out for red flags, which we went through: tuna fish.
Yeah.
And do you want to do the take home for anyone listening? Well, you've sort of done a take
Yeah.
home for, and the only thing I would say to add on to any patients at home is when they are taking anti-inflammatories, if you take one esomeprazole or omeprazole for that day, that will cover it.
Oh, yeah.
You don't have to keep, like, once you've taken an ibuprofen 3 times a day, you don't have to take 3 of them a day. It will cover it.
Yeah.
In terms of anyone who's working in healthcare, you don't actively need to arrange for imaging. And that's due to, like we've just said, it's unwanted exposure to radiation, which we didn't even touch on. But the idea that you could be looking for a problem that's not there, and you will be fixated on it. They could then, the actual evidence suggests that people who get, well, they get imaged for no reason, they actually have a longer recovery. They've got a worse outcome from it. But yeah, and then to utilise your consultation to make sure that they understand what they're going to be getting from it.
Yeah.
And allow them to have time with the physio and let them stick to that. That's a big thing. Physio is such a big thing, and it's underutilized in this country because we just want a quick fix. We want a pill to cover it, and masking it. Same with anything, as you know, if you mask something, it's not going to do well in the long term, is it? Whether that be telling a quick lie, the truth's got to come out in the end.
Yeah. And I think also the last point, which is both for a patient and for a health professional, is that pain doesn't always equal damage. Which was something that I struggled to get my head around when experiencing the pain. But, you know, the thing that they're telling you to do will eventually help. And
it's subjective, so it's one of the hardest things to manage, because an 8 to you could be a 15 to me or vice versa. So you've got to individualise it to each patient. But at the end of the day, whatever is recommended, it should be monitored, followed up, and there should be an end goal. And then if it's not working, then it needs to be reassessed and restarted. You can't just sort of give them a plan and then just leave them.
Yeah.
And that's going to be followed up. But yeah, the plan is to get it from another perspective, a non-pharmacological perspective, and see what it is that we don't understand, or certain things that we might not have brought to the table today.
Yeah. So as always, thank you for listening. And if you have any questions about anything that we've discussed in this podcast or any previous podcast, then just drop us a message. We'll link we'll put some links at the bottom of this podcast to where I said the sleeping, maybe the red flag symptoms of any back pain, so that, you know, you can have a look.
I'll let you find a link because I'll struggle with that one.
I'll have a look.
But yeah, thanks for listening from me, and I'll see you next time.